Joe, I mean, we talked about this with primary ADT, and how do you counsel patients around these risks? And as Chuck said, they're going to be on it for a long time. So we're talking about 2+ years of exposure, just like in that primary ADT setting. And there's a accumulation of the ADT effects, plus now you're adding new side effects and things. What's been your experience in this space treating patients, and how do you manage that? How do you talk to patients? And does any of that factor into which of these agents you think about using in certain patients?
Yeah, I think it's really important to remember that apart from the fact that these patients are suffering the effects of castration, they're otherwise very well. And so I think as doctors, the last thing we want to do is make people worse. Yeah. So I think that's very important. So the side effect profile, I think if you look at the data, they're all slightly different trials, but more or less the same patient population. And as Chuck says, more or less the same type of results. I think the efficacy is fairly similar between the agents. Right. So in making the decision, if reimbursement isn't the issue, then really it comes down to tolerability. So if you get past all the controversy we just talked about and you've decided, yes, this patient will benefit from treatment, then it really does come down to the side effect profile. And especially with active patients and fit active patients, I think you really have to try and maintain that level of fitness. So yes, we can give them lifestyle advice, but we see from the agents there is quite a difference, I think, in the side effect profile when it comes to physical functioning and even potentially cognitive functioning. And to me, in that patient population, that's very important. And maintaining quality of life in somebody who is really well, it's an iatrogenic situation. We have created this illness. Right. So we have, as Chris was saying earlier, we started the hormone therapy. We made a decision to castrate them at some point. Right. That may or not have been the right time, or we don't know that, but we've done it. Yeah. So now they have a doctor-created illness, doctor-created symptoms, and now we're going to do something else. So a perfectly well man, and we're saying, we've seen the data, your PSA is doubling less than 10 months or less than 6 months. We think you benefit from this, but doc, I'm feeling great at the moment. Yeah. And you're saying, I'm trying to delay the onset of something on a scan.
Yeah, you keep doctoring them.
I mean, so we have a big responsibility when it comes to this. So I think we believe it's the right thing to do.
It's true.
But when you're explaining that to patients, I think it's a big responsibility.
And they're not going to see that benefit because there's nothing to see
on
the images.
It stresses them out, though. If their PSA is rising, they're stressed. If you tell them there's something on their scan, of course they're going to be upset.
So if a patient has a PSA of 2 and a doubling time of 4 months, and you talk about starting apalutamide, darolutamide, enzalutamide, et cetera, what's the difference between that patient waiting until he has a PSA of 8, right? That would be to get from 2 to 4 to 8, that's 2 doubling times. That's 8 months that he's not been on a therapy that may induce some side effects. And in the US, we have substantial financial burdens associated with this. We'll never have the answer to that question.
Yeah. Although you're on the study, the median PSA was around 9 to 11
right.
months, 9 to 11. So,
right.
So they did just that. They watched for a few to get an accurate doubling time,
right.
to really be sure. And these are the patients who within 3 or 4 scans had Mets.
Right.
So that's sort of, I guess, the thinking.
Yeah, and although we have to be careful. So if you look at the quality of life that has been published for the 3 paper, keep in mind that it was mostly measured before progression. Mm-hmm. And what we have learned is that it's still yet to be confirmed, but very interesting that actually quality of life deteriorate before you see the metastases on the conventional imaging. So when you see a bone metastases on a bone scan, we know from MRI study that on average it's been there for 6 months. That's the time it takes to seed, grow, and induce the osteoblastic reaction. And meaning that it is very likely that the deterioration on what I'm going to call the body, the health status, is actually anticipating the development of metastasis. So it's about preventing this. So I really believe that the problem is, if you are at high risk of progression, to me, there's no reason to wait. And I would even warn against the new imaging technology, because what we see now is people say, oh, okay, I'm going to do a PET PSMA, I see a bone met, and I'm going to give radiotherapy to that bone met as an alternative to start APA and Daro. And that is absolutely unproven. But I think that this metastasis-free survival was chosen because they didn't want OS and because the regulator wants something very rigid to measure. Mm-hmm, mm-hmm. And actually, when you look and you do like they do for PFS, you do a kind of MFS plus, and you look at everything that is before and after MFS, you get a much clearer picture that waiting that the bone mets is there, especially with modern imaging technology, that we have to be careful. We may lost already a major impact on the quality of life.
Can I pick up on one thing? So MFS Plus is a nice way of describing it. But recognizing regulatory approvals are driven by two things: prolongation of survival, or using a surrogate that you will be prolonging survival with a drug, or clinical benefit. None of these studies, none of these drugs was improved on delaying the radiographic scan alone. It is annotated by the strong secondary endpoints, as Dr. Ryan, Chuck just described. Quality of life has to be rigorously measured in these non-OS endpoints, and they did. Pain, next line, secondary therapy, PFS2, making sure that the first therapy didn't negate the benefit of the second therapy. So none of these approvals are based on the radiographic issue. It's the secondary endpoints, as Bertrand just described, MFS plus. And so when you look at the data sets, yes, great, they met it on the first issue, the radiograph, but let's look at everything else in greater detail. And the other thing that's consistent is survival is in no way being compromised. In fact, it's all trending in the right direction, that early is leading to longer survival.
And that was the newest thing at ESMO, right? That we saw, that Matthew Smith presented, that we're almost there. We're so close, right? I mean, this is like on the rim of the hole for that ball to just fall in as a definitive. Do you want to summarize that data real quick?
I do. What I do want to say is, when I personally look at data sets, and we'll come to this when we talk about the hormone sensitive, I look for consistency and reproducibility across the three trials. And all three trials are all trending in their early analysis before they've had enough survival events that it's trending in favor of overall survival. So if you do it in aggregate, and I would have Bertrand eat his hat if we do not see an overall survival benefit if we did an aggregate meta-analysis of these. So team, when we look, and I'm talking to the team out there as we're treating our patients and we're counseling them on the benefit, let's look for consistency and reproducibility across the studies wherever they're done in the globe.